Lee was going to present this part. I'm just checking to see if Lee is on the call. But Lee was working last night, so he may not be able to. So can you see the participants just to be sure? I don't think Lee's on, in which case I'll present it.
I can't see Lee.
No. Okay, that's fine. So we'll go ahead. So Lee Sumro has done a lot of work, and he created the slides that you see now. And what he was tasked with, along with the Resus task group, was to look at the layout that we could use for the temporary Resus area in B and C. And Jamie, I think you're on the call, and perhaps Dan, and you may wish to come in. But I'll run through these, and then if you'd like to add something, please do. So essentially the plan is while Resus is going to be out of commission and our main Resus will be completely closed for construction and refurbishment to put the sliding doors and the other changes that have to happen. So we have to relocate Resus. So effectively what we're going to do is we're going to use areas B and C as the resuscitation area temporarily while the works are going on. And this has been used as a resuscitation area before, so we do know that it can be used. You can see that Lee has laid it out with the green spaces showing sort of standard Resus rooms. You can see Resus room 1, 4, 5, and 6. And then he's placed Resus 2 and 3 in the sort of red color there, with the trauma towers in between. And the reason for that is that allows us to have slightly larger rooms in those areas, which are going to be directly across from the nurses' workstation, so that they're easily observed. And then if you look into area C, we've also got 2 additional lower acuity rooms, as well as a pediatric resus and sedation room where the pediatric equipment will be housed. And then we've got a side room, which will be similar to our current side room 5. So effectively, we end up with, a reasonable number, same number, I think, in fact, of resus bays, and then an additional side room and a couple of lower acuity areas, which we see could be used for resus step down. The ones which are highlighted in green and in red, and the 2 side rooms are the ones which have got oxygen suction and other requirements for resus care, whereas the low acuity ones don't, and it would be portable oxygen and suction in those spaces. So we wouldn't want to put high acuity resus patients there, bearing in mind that we will still be using the ambulance bay as red resus. So these will be these are going to be the patients we are currently seeing in main resus, and they'll just be relocated to this area. They'll come in through ambulance bay, come along the corridor through area A, and end up in areas B and C. Do you want to go to the next slide? Jamie, do you want to add anything? Oh yes, we've talked about relocation. Andy's just pointing out to me the blood fridge and the fluid warmer will be relocated into the corridor space across from the kitchen. But otherwise the area will be used as it is, and there is red phone facility in that area. And here's a mock-up of the space, and I think Jamie and Dan have set these up, and you can see how the spaces will look. And you can see that there is adequate space for a resus cubicle, particularly the one where the resus tower is shown. And also those are movable. So if we needed a large trauma bay, it would be possible to open that out as a single bay between the middle 2 and straight across from the nurse's station. And the other thing that Emily's going to do is make sure that there are curtains that go all the way across, so that we can use the bays as they were laid out rather than the way the curtains are currently laid out. So that's in the design. So this has a small renovation to go through. And that's just to show you what room, the side room, the C8 looks like. And that's what we're envisioning will be a pediatric resuscitation room. And it'll have the pediatric equipment in it, as well as the Panda warmer, which is the replacement for our resuscitator. And some of the pediatric stacks will be in there, and cannulation trolleys. And then the next part of the plan will be that we have to obviously displace the activity that currently goes on in areas B and C. So when that happens, what we will do is we will move to using area A as the amber stroke red, but effectively the amber area, which means area A isn't changing in layout at all. It's just that its function will change. So instead of seeing the patients we currently see in B and C, in that area, we will be seeing them in area A. And I think we recognize that the pandemic is a moving target. We don't exactly know what the numbers will be at that time. Obviously, we're hoping we don't have a huge uplift in the number of patients with COVID, but we expect we will have still a number of patients who will meet the Public Health England criteria, which means they'll have to be considered amber until we can step them down to green. So we will still have a need for an amber area. So we're going to convert A to that, and then if you want to go on, and then what will happen is area D, which is currently used for this purpose, will continue to be used as the green area. And you can see we're going to try to use the front cubicles as we usually do for ambulatory patients, and then the back cubicles as we currently do for green patients who require trolleys. So what it does is we effectively will lose our 7 Resus cubicles. We'll shift the work around a little bit, and that means we're 7 spaces down. So we do have a contingency plan for that. EAU3, which is 1 level above the current pediatric emergency department, is currently unoccupied, and that space is going to be used for patients who are ready to proceed to the ward. So the idea will be that once a patient has been seen and they're under the care of a specialty team, and they'll be cohorted in that area, and it will have to be staffed with nurses, and we have some confidence that we can staff that area if we have got a full complement of nursing staff in our department. But we realize that that's a difficult ask because our nursing staff has been under tremendous pressure. So we have requested from the trust that they will help us to staff that area. And that's something that we're working toward at the moment. And what we would hope is that there's minimal need for medical input from the emergency department in that area, because obviously it further opens up another area of footprint for us. So for safety, we will be moving the patients who are clinically stable and ready to go to the ward to that area. And I think obviously it'll be an area which will not be opened if we don't need it, but if we do need to expand into that space, we'll look at staffing at the time and we will make the decision whether it's safe to open that space. Helen, do you want to add something to that from the nursing point of view?
No, I think, like you said, it will very much be a 219 and EPIC decision, and dependent on what the staffing levels and what the organisation are able to support with on the day.
Yeah, so we're looking at that as a cohorting area that can be accessible to us when our department becomes full, in the event that we have got adequate staffing to staff it safely. So that is a contingency plan for the crowding that we anticipate while we're moving.